Oh, very good. Now we can begin. Uh, the single most important thing to begin to decide is we're most likely today, possibly a little overlap on Wednesday, going to finish this chapter. It suggests to me that we have to figure out the time for the exam. What I was looking at up here to show you. I do not know what you have coming in, but I would suggest it's one of these 2 days. This is obviously our last day here. I would say either the 14th or the 17th. So unless if you email me or something, a decision will need to be made soon. So I don't know if you prefer to have them because a lot of times you get hammered this week. And I didn't know if you wanted to have it the week before. Don't know. So I mean, any strong feelings one way or the other? I'll make an executive decision. Let everybody know on Wednesday here. Ah, it's harder because we have 3 classes of, and most of you are taking a very similar series of course load material. So that's the major focus today. And I did send you the PowerPoints, and I'll be doing to all the classes. I just started to get it together this morning. This will be the nerve physiology. I'll be sending the Welsh Hall ones. Make sure I have all of those. It'll be low. So the next unit will be located under Unit 4. I may or may not have some outlines to send with that as well. We'll see what I have going on. I still have to look for maybe some other printed stuff on the neuromuscular junction and things. But I don't know if I have time today, but I'll probably have some time tomorrow. We'll get there. All right, let's begin where we left off. So we had finished all about the energy and the aerobic and let enough air into that discussion, etc. So really, this is the last of these 3 PowerPoint sequences, and a lot of it's on something that's somewhat unfamiliar. Smooth muscle. So I probably will be introducing that. Maybe we'll get through some of it today that are there. How it's about the cross bridges. So, and then there's a couple of different things as we want. For instance, you're lifting something that's heavier and it starts light, and then you recruit, and that's the name that we give to it, more of these motor units. And understand, and it's implicit, in other words, something anybody would understand, the size of the muscle plays a role. That's what exercise is all about. Muscles, there's a difference between making more cells and making the cells bigger. In muscle, we can't make any more cells. So hypertrophy or growth, hyper and growth, more growth is where the name hypertrophy. And you see hypertrophy in a lot of things. And in general, that's the term we utilize. And typically, if desirable, it's beneficial with regular exercise. And then we get a little bit into the ways you can do exercise physiology, just as an additional aside. And here again, this whole idea, frequency is the big player. Okay, the higher the frequency, the greater the force. When we continue, again, that additive effect or summation of the stimuli until we reach a maximum level of stimulus is also a part of this. And then this is really interesting. And this is so physiologically important, and you'll see a very good graphic on it. It has to do with the degree of muscle stress. Okay, the sarcomeres have a length that's desirable. You heard about muscle tone and resting tension. So, I mean, they're already a little bit contracted. So the golden areas you will see is roughly being, if 100% is basically the muscle at complete rest, if it's slightly contracted or slightly more relaxed, wrong way to express it. If 100% is its normal resting tension. If it's a little more contracted or a little more relaxed, just a little bit, 20% off that midline, okay, you can still generate maximum force, more or less, from that muscle, as you will see with this graphic. You're going to see if it's less than 80%, there's too much overlap. This is, I never try to make it like it seems like I can understand physics, and I don't. But effectively, it's sort of like this. If you get somebody who's muscle bound and the muscles are already massively contracted, it's already so overlapped, you can't generate. You get force is mass time acceleration. You might have mass, but you can't accelerate it very much. So you can't generate the force. It's a physics thing, what little I know about physics. That's why, and why where I think the most important aspect of this is what's called an enlarged heart. That's what high blood pressure does. High blood pressure, when you get to that next term, for most of you, is a silent killer. It's silent because your heart has to work harder to basically force open the blood vessels to circulate the blood. And so it's like any muscle that's exercised excessively, it's going to enlarge. In general, if you're thinking about making your arms bigger, your legs bigger to generate more power, because that's your aim, that's fine. But with the heart, not so good, because you get to this point of diminishing returns where, sure, I can overcome it, but now I can't, I lose my efficiency. I can generate the force, but I can't push the blood around. And that's why when we see an X-ray or we do a study and it demonstrates an enlarged heart, that's bad. But it's a lot harder to change that around. That becomes really a very damaging diagnosis. And this is when it's overly stretched. You just can't get enough traction on that ratcheting. You can't engage enough of those myosin heads to make it happen. You're gonna see the graphic. So this is the frequency or temporal summation. We looked, we let enough air into that, whether it's unfused tetany, whether it's staircasing. How many muscle fibers make sense? Large muscle fibers make sense. The stretch thing is very significant as well, and all of those basically add up to how much force we can generate. That's the best way to understand what's happening with muscles. This is the diagram. So here is what we would call the resting tension or resting length. There's a certain degree of overlap using that same schematic you saw before. Here, when the muscle has already been overly developed and it starts overly contracted, you just can't shorten it enough to effectively create the kind of force that's necessary. And here, it's overly stretched, you can't engage it. And I think it's a very telling graphic about that. Obviously, they've gone to an extreme here. 170 is more than, certainly way more than 120, but it demonstrates the concept, I think, very well graphically. Be wary of that. So, and now we get into the fibers themselves. The fiber, and certainly the load, is how much we have to lift or to move. And recruitment is just your body basically saying, I didn't think this sucker was going to be this heavy. Believe me, I experienced it yesterday. We have more acorns. Literally thousands of acorns. And when you shovel those up, oh my goodness, as they get heavy in a hurry. So we had an acorn workout. So you have different kinds of fibers. And typically you're going to see there's often a mixture of these kinds of fibers. And much of this is genetically determined. And it explains a lot of things that sometimes people have difficulty accepting and sometimes having difficulty, grasping the idea. So you have slow or fast fibers. And so all of this has to do with basically the interior aspects, the enzymes that manage to break apart ATP, certain patterns, stuff I don't even want to get into. So we call them oxidative for aerobic or glycolytic for anaerobic. Oxidative ones using oxygen, glycolytic rely on that glycolysis that we talked about with regard to energetics last time. So skeletal muscle fibers, and you can see we have either slow, we only have three types: slow or fast oxidative and fast glycolytic. Most are a combination in a range of contractile speed and fatigue resistance. Okay, in a particular motor unit, that one particular area that acts on, that particular portion of the nerve is stimulating will all be one type. And this is the big deal, it's genetics. So I joke all the time about my vertical leap. I mean, I am the prototypical person who's not terribly athletic, but loves sports. Okay. I wish I was. I'm never going to have a vertical leap like that. I'm never going to be able to run that fast or jump or have that kind of hand-eye coordination. It's a gift. We all want the gift. You can develop what you have very well. And so if you find something you can do, you can certainly refine it. That's there. And that's what people have a tough time. I have patients for years telling me this guy was a tremendous athlete. Okay. Couldn't understand why. He went to school on a golf scholarship, got into running and distance running, desperately wanted to qualify for the Boston Marathon. Had no idea why he couldn't, and it's age-based criteria. I mean, you're trying to tell him it just doesn't work that way. I mean, you're doing everything right, but physiologically, there's a limit. Even with the best kind of training and the best kind of preparation to be able to do that, you can't. He had to break under 3 hours for his particular age group. I think he was in his early to mid 30s. Couldn't do it. And a lot of people, if you didn't know, up in Presque Isle, if you're familiar with that part of Erie, they have a marathon up there. It's very flat. That's the one you try to, because you have to have a marathon like that that's very, very flat. Like my son just running the one in D.C., the Marine Corps Marathon, very, very flat. So they get good times. And that's where you try to go to qualify for Boston, which is very hilly. That type of thing. So it's all about that. So the different types are better suited for different jobs, not jobs that you would be employed at, but jobs that you would do with your muscles. So the slow oxidative, low intensity endurance, oxidative. So if you think about that, that's the idea of aerobics, maintaining your posture. Fast oxidative, again, sprinting, sure, but also walking. Again, so these are more of the overlap into potentially being aerobic type activities where you have either enough oxygen or, relatively speaking, for the task at hand, enough oxygen. Where this is the short-term, intense, powerful movements. Okay? So whatever it is, if you see the velocity, if you just watch the World Series, you can see the velocity of some of those things. Nowadays, we have all those wonderful metrics to tell you exit velocity and how fast the ball is and all that type of stuff. Very, very interesting. If you like all that a lot of people do. I'm not. I'm more of an eye test kind of a guy. So moving on, predominance of fast glycolytic fibers, which are by their very nature fatigable, okay, because they function with or without oxygen. So inherently there's a limitation on their resources. Small load, you bring more into play. Slow oxidative, fatigue resistant type fibers, postural muscles, almost muscles that we generate just for routine getting around. And so, but velocity and duration are employed. And that's kind of the look at this. And you can go through this chart. Frankly, there's not a whole lot of questions on this particular aspect because I think a lot of it is intuitive. The one with that 80 to 120, that's important. The fact that there's a mixture of fibers that we're sort of born with, that's important. Other than that, this is more of just trying to give you enhanced understanding of muscle that's there. So muscles contract fastest. Gee, I can do this faster than if I have a 50-pound weight I'm trying to curl. Boy, they had to put a paragraph in on that? I don't think so. The greater the load, the shorter the duration, all right? Slower the contraction, and we got to bring more guys into play. Thank you. Didn't know that. Didn't know that. Endurance exercises, all of those. This is the importance physiologically. Why aerobic and aerobic exercises from a rehabilitative? If you're going to anywhere in healthcare, the reality of healthcare is you do often with most often with people who are impaired or sick or have to be rehabilitated than people who are well. It's the nature of the beast. So already you're starting with a deficit. And so this is one of the great ones that are part of it. It's something that a lot of people are slow to realize because until you're confronted with your own mortality, it doesn't quite that doesn't happen to me. And that's an attitude that's very pervasive. Most people are like that until something confronts them or something close in their orbit confronts them. So all that type of thing, without getting too preachy about it. So what it does, more capillaries, more mitochondria, more myoglobin, all endurance, strength, fatigue. Even some of those glycolytic fibers can convert. That's why the whole idea of doing the aerobics, of doing the cardio, of doing that kind of training, particularly for endurance, is so terribly important. I mean, that's why I keep looking at how many steps I'm getting in during the day, just trying to do that. See, I have my eldest was, I go, man, I am beat. It was a rough week last week, blah, 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 blah. Like this, you figure that your eldest child, soon to be 43 years old, would have something kind to you to say. Well, why don't you retire? He's just mad he didn't get paid. He's in the military. They didn't get paid. 30th. Resistance exercises. 2 ways, basic. These are called PREs, or progressive resistant exercises. The way to strengthen. I mean, I'm not going to, I'm by no means an expert on this. If you are someone who has experience in training, or you're working with somebody, do what they say, because they know what they're doing. In general, from a doctor perspective, when someone came with a bad knee or a bad ankle and we wanted to strengthen it, we recommended PREs. So basically, the whole idea is you set up a program, maybe 3 times a day, maybe 15 repetitions. You start with either no weight or a nominal amount of weight, and you progressively increase the weight, i.e., progressively increasing the degree of resistance. Okay? You don't want to increase the frequency, you don't want to increase the number of reps, whether it's just lifting something up, with a knee, doing a straight leg with weight, and you can put any kind of weight over it. You could do, fancy weights with Velcro. You could put a paper bag with a couple of cans in it and lift that up. Doesn't matter. Any way that you could rig something up with weight and just keep adding a certain amount of weight. And every week or every 2 weeks, you gradually increase the weight. That's how you develop strength. When you're looking at range of motion, then you're looking at a similar thing, but not with weight. Okay, you may put a certain amount of weight, but it's all about increasing the repetitions, the frequency of the repetitions, the duration of the repetitions, that type of stuff. So you're trying to encourage range of motion. And sometimes we have to do those things, like when I talked about electrical stim, they're being done passively. I don't mean to take the place, and maybe today that was our physical therapy type of intervention, our recommendations. And usually, for me, it was much easier because you just send somebody, if it was becoming complex or there was a post-operative problem, you sent them to physical therapy and let them utilize their expertise. So that's part of it. So this is the idea. Typically anaerobic weightlifting, isometrics, thickens the muscle, increase size, and in doing so, it strengthens. That's part of it. And this is one of the problems. This is all about use it or lose it. It applies to every system as far as I'm concerned. That's their atrophy of disuse. So atrophy meaning actually without growth. And the problem is not only is it's understand when it's not doing something, when it's not quote unquote growing or using its metabolic properties properly, it unfortunately begins to deteriorate. That's the nature of what happens in our bodies. And classically, we see it if someone's in a cast for a period of time or has to be immobilized for a period of time. And it's so brilliant to see it with young people. Oh, look, their muscle mass is down, and in about 2 weeks, it's all back. Because your reparative processes are so good. On the other side, okay, much more difficult. And it happens right away. The older you are, that's why there's been such a change from the traditional immobilizing in a cast, which couldn't be removed, to using these sort of removable casters. They're hard casts, they're very interestingly engineered. You can take them off, you can do skin care, local care, wound care, start doing physical therapy even when, in the moments when they're taking that off. It's a whole change in the way the care has been done. And it's very, very progressive, and it really has. As you can see, 5% a day, paralyzed muscles down to 1/4 their size. Once those muscles effectively die and are replaced by fibers or scar tissue, you can't rehabilitate those, or you can't rehabilitate that part of the muscle whatsoever. It's lost. That's part of the reason you're typically, particularly in orthopedics, very, very aggressive with doing this kind of things. You'll see if you're going to work in a hospital, you'll see these things. How important it is to get people out of bed and moving around, because not only does that encourage the muscles to be used, when people are sedentary, the older they are lying in bed, it makes 2 things very possible: blood clots, respiratory problems. I mean, we had routinely women and men in their 90s after hip surgeries where we had to put hip replacements or repair fracture hips. They're up in a chair within 24 hours. They're down in physical therapy probably within 36 to 48 hours. Because that's a blood clot. That's an accident looking to happen. And you'll see that. It'll be surprising. why those things happen. So that's everything. So that's everything we really have to cover on skeletal muscles, which leaves us a fair amount of time here in the next 20, 25 minutes or so to start talking about smooth muscle. Maybe we'll get through it. This is our interest here is basically the anatomy and physiology of the smooth muscle because it's different. You're going to deal with these constantly in AP2 because all of these systems have tubes. They just are all a bunch of tubes, whether they're digestive, urinary, reproductive, circulatory, all of those things, and barring capillaries, which is really where the exchange, oxygen coming in, out, carbon dioxide coming in, nutrients out, waste products in. Those are the exchange vessels. All of them have a certain amount of smooth muscle, period. And the arrangement of those smooth muscle and how it works is significantly important. It's a totally different thing. Anatomically, there are some limited similarities, but it's different. Okay. The heart contains cardiac muscle, not smooth. That's a whole instance of itself that I won't even deal with it here. Again, that's striated but involuntary. What we're dealing with smooth is we can't see the striations and it's involuntary. We don't have any conscious control over that. So most smooth muscle is organized into sheets, tightly packed fibers. Very, very different. So, and typically we'll see these oriented at right angles. This is the classic. Thank you for having the paper here. It really makes my job easy. The word we see a lot of and that you'll become familiar with is called peristalsis. Peristalsis is something you don't have to know for this, but you're going to have to know extensively. It's sort of the segmental movement of fluids and material through these hollow tubes. So effectively, you have a tube. The interior of the tube is called the lumen. The sheets are on the outside. Typical arrangement, longitudinal on the exterior, circular on the longitudinal, circular on the interior like this, longitudinal on the exterior. And so what they do is they squeeze and push, squeeze and push, squeeze and push rhythmically. That's the way you move food through your gut. That's the way you move a lot of urine getting effectively into your bladder and starting the process of getting out, ejaculating sperm. Pick one. Moving the egg down the fallopian tubes. Squeeze and push. It's all because of this arrangement at right angles of circular fibers on the interior, basically deeper around the hole, which is called the lumen, a name you should be familiar with down the road. And then everything else flows from that. So peristaltic movement, sometimes it goes backwards, reverse peristaltic movement. Very important stuff. So longitudinal, parallel to the long axis, contraction, fibers circumferentially, constriction, alternating, blah, 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 blah. Mix and squeeze, fine, I'll buy it. Push and squeeze. It's like getting a toothpaste out. When you're at the bottom, you know what I mean? You know what I'm talking about. You know, fold that bad boy up. Can I get it out? Okay. Right. The fibers are spindle shaped, not that longitudinal arrangement with the sarcomere and the fibers. Fiber again means cells. They're thin and short compared with skeletal muscle fibers, which are wider and much, much longer. One nucleus, no striations visible, but we'll go with it. Only has the endomysium. You don't have all that elaborate stuff going on with it. Okay? You don't have a neuromuscular. This is a lot about what you don't have. It's a typical question. There'll be a few on the exam. Is really looking at the differences. All of these are true about smooth muscle, except, or the smooth muscle differs from skeletal muscle by all of these things, except. Got it? I know you don't love those questions. I'll try to stay away from the A and B, B and C. Could be A and B next week, but B and C today on sale. Nobody's laughing about that. You didn't stay up late and watch that terrible game last night. It's okay. Stop. One day I'm coming in here and I'm bumping this coffee up a notch. It'll get me through the day. Particularly for somebody who doesn't drink. Contains varicosities. A varicosity, normally you're going to hear about it in the context of a vein. Affectionately, a varicosity is a bulbous enlargement. So rather than having that elaborate neuromuscular injunction, when you see the illustrations, they store and release neurotransmitters, and the synapse is wide. It's called the diffuse junction. All of the autonomic nervous system, you could substitute the word automatic. That's the very last chapter we will do prior to the end of this course, right before the final exam. It has very, very limited. You're going to see acetylcholine is still a very big player in this particular system. This is what it looks like. So here's these sheets. So here they're small, small spindle-shaped spindle. They're narrow on the edge, wider in the middle, and that influences the way they contract. Here you can see the autonomic nerve fibers and these enlargements. And yes, there's mitochondria. And yes, there's synaptic vesicles. You're going to see most of these release acetylcholine. You'll also see something when we look at neurotransmitters called norepinephrine. I save that for the next chapter when we really look at the system, rather than to here is more generically looking about the general anatomy and the general physiology of this particular system. It has a much less elaborate sarcoplasmic reticulum. It doesn't have the T tubules. They're not big players. The sarcoreticulum does store intracellular calcium, but the big deal, just like the nerve firing, extracellular calcium. The smooth muscle contracting, extracellular calcium. That's why you will come, if you're going into a medical or clinical field, nursing field, whatever, and you look at someone's medications, if they have high blood pressure, if they have cardiac problems, they're going to have something that I take. They're called calcium channel blockers. They are the go-to. If you ever look at the top 5 prescribed medications, in all cases, calcium channel blocker. They've been around forever. We just keep modifying and make different ones. They block the calcium from either entering the nerve and causing it to fire, or entering the smooth. So think of what it does. It affects the heart, which relies on extracellular calcium, as you will see, the nerves that fire skeletal muscles, and particularly these smooth muscles. So it relaxes blood flow. So that's why it's a go-to treatment for blood pressure. That's why it's a go-to treatment with regard to heart problems. They automatically put people on calcium channel blockers. I've been taking one for ages. Same one. When I was in practice, I started prescribing it for other things. We use calcium channel blockers for other problems. So that's a big deal. Intracellular calcium is skeletal muscle. Extracellular calcium is really the linchpin for nerves, smooth muscle, cardiac muscle. So this, rather than having the sarcolemma, rather than having those T tubules, have these little infoldings called caveolae. Numerous calcium channels that allow the extracellular calcium in. You're going to see that. So caveolae is an important word. Voila, not a bad illustration of it. Yes, we got a sarcoplasmic reticulum. Yeah, it doesn't look anywhere near the same. Yeah, it's got calcium channels. Okay. And interestingly, the calcium channels from without influence the calcium from within. That's what you're reading from this illustration. Yeah, and again, when the nerve impulse goes through, if the neurotransmitter is released, it causes that voltage-gated calcium channel to open within these little indentations they call caveolae, and boom, that causes that particular smooth muscle to begin to contract. We're not done with the differences yet. They're usually electrically connected, the individual fibers, by gap junctions. Okay. Skeletal muscles, as you go back and look at those diagrams, it's a different nerve for each fiber. Okay. It's a different motor unit for each one. We just use more the more that we need to contract something or lift something or move something. Here, there's contracting. So again, go back to that stupid thing with squeeze, push, squeeze, push. It's segmental. One does it, the next one does it, the next one. You're doing it right now. There's nothing more active than your gastrointestinal tract right this very instant. I've said it before. What you're going to do if you're going into nursing, particularly when a patient's in bed, one of the ways you assess to see how they're doing, because you're sitting in bed, is, do I hear bowel sounds? Little clinks and plinks that you're going to put with a stethoscope. You're going to auscultate them. It's all right. You won't get arrested. That means listen with a stethoscope. I could have said palpate. That's when you touch them. You know, I'd be in a better mood if even I would get an occasional smile. I know you're sleeping in the back. I need more sleep. Why am I up? Okay. Specialized cell connections. We know no striations. You can see no sarcomeres. They do contain thick and thin filaments. Okay, we'll buy that. So here's the difference. The ratio is so much different. Here it's 12 or 13 to 1, depending on the author you read, versus in skeletal muscle 2 to 1. Remember, I talked about that before. Obviously, there's a test question in there. Like the 16th, when you mention something 16 times, you're trying to get people's attention. Okay? Thick filaments have heads along the entire length, making smooth muscle as powerful as skeletal muscle. Okay, tropomyosin, yes, troponin, no. That's another big difference. The whole idea of skeletal muscle, again, calcium enters, the troponin changes shape, the tropomyosin moves around. Here we don't even have any troponin. We have a different protein. It's called calmodulin. It binds to the calcium. And so what happens here, you can see sort of the way it's shaped. Here's this interesting thing with the nucleus. And so what you're going to see, you can begin to see which take the place of these. We have dense bodies, which kind of basically are a little bit like those Z discs, if you want to think of it. And you can see the pattern that's there. It's very interesting. It's there. So you have intermediate filaments. If you remember, going back to the first part, when we talked about microfilaments, we talked about microtubules. In between them were insoluble fibers called intermediate filaments. They gave the strength, that type of thing. So they have intermediate filaments that really reinforce the shape, and they have these dense bodies. They kind of make sure it maintains that shape, but still permit it to contract, would be the way to describe it. So the thin and thick filaments are on a diagonal, spirally arranged. So the muscle corkscrews, as you will see. The intermediate filaments in the dense body, if you go back and look, when I say lattice-like, you can see that sort of crisscrossing kind of arrangement. That's what they're referring to there. Okay. And the arrangement, the intermediate filaments don't contract. They're just maintaining the shape even when it contracts. The dense bodies anchor those filaments, very correspond to or comparable to the Z discs. During contraction, the areas of the sarcolemma between the dense bodies bulge outward, and it looks a little puffy. Voila. It spiral contracts like that. So you take something and go, it bulges in the middle. And at the same time, that's with the puffiness. You can see, look at the nucleus. I mean, it's not that again, it's a flexible structure, the nucleus. The nuclear membrane is flexible in nature, so it reflects what's going on in the exterior, as you can see. And voila, it has contracted. So those are all important points to go back over them. Why am I going back over them? Because they're on the exam. That's right, ladies and gentlemen. So what happens? Caveolae are the indentations. Yes, that's the comparable thing. They're a little comparable, if you will, to the T tubules, because that's where the voltage gated channels are, except these are all about calcium. And yes, it will help induce some extra calcium through it that are there. And yeah, there's gap junctions that connect it, but we don't see the sarcomeres or the visible striations. Obviously, the relationship, you have tropomyosin, but no troponin. That's important. And what happens, you're going to see subsequently how effectively it induces the contraction that are there. Intermediate filaments in the dense bodies, that's the lattice-like arrangement. It sort of gives that, basically the nature of the, how it contracts sort of defines how, in what direction or how it will contract. And that fact that it contracts spirally and looks puffy in the middle. And so you can see that over here and over here and over here, all that good stuff. So I know I buzz through those really fast. I do that because it's not, to me, it's not terribly important. Okay. Here, what they're showing you here, these just have an endomysian, actin and myofilament. Actin and myosin are there, but the dense bodies are anchoring the actin. No, none of the other stuff, T tubules, just antibodies. And this is where they're showing you the comparison. Here we're looking at the smooth muscle again. It's unitary, just one. You can see that here. This is the guy, this calmodulin plays a role, and you can see how we don't have varying degrees of speed. It's all relatively slow. The heart is slow and steady. These can be slow and fast, but they're relatively slow. Slow, synchronized, orderly is the way that that works. The gap junctions are there. Some cells are even self-excitatory, okay? And you'll see the areas where this occurs. A lot of times it's stretch receptors and chemical receptors, and some of these just kind of go on their own to make sure they continue to go. I mean, that's a little bit more advanced without having to go, which one does this or which doesn't do this, okay? And again, there's a lot, and there's ways we can modify them. You're going to see when we do the autonomic nervous system, when we go into fight or flight, this slows down. All of a sudden, your gut, your urinary tract, basically, it almost goes to a standstill, minimal activity, because right now you're either running away or hiding from something or fighting with something. You have to devote all your energy, all of your vasculature to your heart, to your skeletal muscles, to being able to breathe, to do something very, very rapidly and powerfully, because you're at risk for whatever the reason. This is the whole idea. So you can see that that happens. So without going crazy about that. So the actin and myosin, okay, they slide by that. Interest calcium, yeah, great. It is a trigger. ATP, yeah. Contraction stop when the calcium is no longer available. I got that. So there's nothing here really new under the sun. The contraction is different from skeletal muscle in the following ways. Even though some calcium is obtained from the sarcoplasmic reticulum, mostly extracellular. Troponin doesn't exist. The chemical you have to remember is calmodulin. What you don't have to know about are the enzymes that it activates, the myosin kinase or myosin light chain kinase, and that one basically leads to the cross bridges. It's enough to know that the calmodulin will trigger. The advanced students, that's where they get this. They get into the enzymes when we do advanced physiology. So more steps than skeletal muscle. Calcium has to detach. Calcium has to be active transported into the sarcoplasmic reticulum and kicked out. And yeah, we have to have something called dephosphorylation of myosin to inactivate the myosin. Don't worry about that. When it stops, it stops. We're not going to go into the gory details. Effectively, if you know that the calcium is either being pumped out, pumped back in the sarcoplasmic reticulum, or pumped out of the cell, that's fine. So they're showing it to you. The calcium enters by those voltage-gated channels. As it enters here, effectively, look what happens. This is what happens. The calcium enters. This is the calmodulin. It changes shape, like any other protein. When it changes shape, it's going to activate that one you don't have to know about, the kinases, and that's basically going to be the trigger for the same kind of myosin head contraction you're familiar with. That's the whole. So this is the big player for you. Calcium to calmodulin, and that basically starts the sequence for that spiraling, bulging contracture of smooth muscle. Slower to contract and relax, but maintains contraction for prolonged periods. Okay? All of these things are designed to save energy. Constant without fatigue. These are endurance muscles. Okay? And mostly by aerobic respiration. We use them constantly. Blood is constantly, your GI tract, barring that rare instance of thing we call fight or flight, is constantly doing stuff. Your genitourinary, you're constantly doing things. Your respiratory, circulatory. They're always busy. If they're not, big trouble. And you see, and things go wrong with them all the time. That's really, this is more about setting your understanding. When you get into the more physiologically based, AP2 is much more physiologically based. AP1 is much more anatomically based. Bless you. That's kind of what happens. And again, that's why understanding though the physiology of them down the road is where we get the pharmacology to treat it. When we understand disease processes that affect it. That's kind of where all this is. But if nothing else, again, it's crazy. Skeletal muscles all about power and strength. Smooth muscles all about endurance, constantly working. The blend of strength and endurance is that unique player pulled cardiac muscle. That's what makes it so remarkable. It has the best of both of those worlds. Would be the way I would. And then you look at the neural regulations. There's lots of things that affect it. Not just nerves, chemicals that are in the area, local changes. Read that as pH is part of them. They work differently in acidic and basic environments. Some are designed to work in one, but not the other. A lot of them work on what are called stretch receptors. When you get to understand the GI tract, okay, most of the way it's triggered is something enters it and it pushes it apart. And then what are the chemical content and how concentrated the material? So that's when the idea of osmolarity that you'll get more about in AP2. They are all the controls. We don't control them. Just when stuff goes wrong. I don't know. Ask your, assuming that none of you are parents, which I don't know. Okay. Wait till you have a colicky baby. Colic is involuntary spasm. Okay. That's caused by something going wrong. It causes the smooth muscles to spasm. And I'm up all night walking around with kids who are crying and screaming all night. Yeah. That's why I'm so much more fond of my daughter, who wasn't like that, but the boys were. So, binding of the neurotransmitters, same thing. Local potentials, action potentials, response depends on the neurotransmitter release, what kind of receptors. Okay. And as you can see, this is the idea of changing things around. And that's when we get into the autonomic nervous system. You're going to see we're able to shunt blood in different directions. We can slow something down. We can accelerate something else. That's the beauty, the intricacy of it. Hormones as well. We're not going to get into G protein receptors. Other things, very influential, as you will see. We have a lot of triggers that are based on, and this is where pH comes in. Carbon dioxide, pH, and low oxygen. The take-home point for this, everybody, is extraordinarily important. Everybody thinks, and this is breathing. What triggers my breathing if there's not enough oxygen? No. That plays a role, but not immediately. Carbon dioxide. Increased carbon dioxide is the number one trigger for your respiration. The carbon dioxide accumulates, and what it does, if you remember the carbonic acid buffer, you're going to see that several times in AP2, all over the place. It begins to make you more acidic. It lowers the pH. Those are the big triggers for breathing. If you have to rely on oxygen triggering your breathing, you're in big trouble. Big trouble. Divers, when they do a free dive, they purge 3 major big expulsions of air, big exhales to purge carbon dioxide so they can do a free dive. Some smooth muscles respond to both neural and chemical stimuli. There's a lot. And there's lots of things that go on. Okay, responding to stretch, briefly, length and tension changes play a role. Again, we're not going to get into all of that. And then there's fiber arrangements. We're not going to get into all of that either. Okay, whether it's visceral, hollow organs, this is that longitudinal and circular, the varicosities, different things. These are the ones that are self-stimulating. Spontaneous action potentials. Wait till you get to the heart. You'll hear plenty of that. And all of those things. And I don't go into all the units and stuff like that, because I think it's just more than you need to know. Well, we finished it. So this is the end of all the material, and there's a lot for the next exam. I can tell you the next exam will have 50 questions or less. That is all. It'll be relatively concentrated. I sent you the study guide, didn't I? Just read it. I was in a good mood after the football game. Trust me. Goodbye. See you all Wednesday.